him?
Thyroid hormone is a very, very important hormone for the body. It regulates body's metabolism. It's a very important hormone. Regulates metabolism of all organs in your body. And so, I mean, I have some slides about what the thyroid gland does and all those kind of things, but basically, we divide thyroid problems into two things. One is problems of thyroid function and problems of thyroid anatomy, hyperthyroidism, hypothyroidism, and that's usually separate from the anatomy, shape, and size of thyroid, which is like nodules and cancer and all those things, which is related to the shape and size of thyroid. So basically, this functional problem, hyper and hypothyroidism, we'll discuss earlier, and then later part will come to that and those anatomical problems. They can be related, but they can be, in most instances, I would like to keep them separate so that there's no confusion. So that's a thyroid, nice looking normal thyroid. It sits on the base of the neck. We went over that, won't spend much time. Butterfly gland, nothing new here. So this is thyroid hormone. It's like, funny structure, some circle, some line, something, which that's boring, that's boring. And nobody cares about those circles, even I don't care about those circles, who cares? So we are here for fun, and this is my motto for today, that, I'm going to make some of the boring stuff fun for you. Because thyroid can get as boring as you may want to make it, and as funny as you want to make it. So basically, what is thyroid hormone? So that thyroid hormone is that, what's that? That's gas pedal. Basically, it's your gas pedal of your body. That regulates your body's speed, how fast your body goes, your metabolism of the body. So that's what thyroid hormone does. It's essentially a gas pedal to your body. Now, there are two types of thyroid hormone, T3 and T4. Basically, what a thyroid does is it takes a protein and puts some iodine, and when it puts 3 iodine, it's called T3. And when it puts, but that's an active thyroid hormone, but that's kind of unstable. So where it puts 4th iodine on it, makes it more stable and secretes the T4 into the blood. So major circulating hormone is T4, but the active hormone is T3. Once again, those boring things, Now, the only difference is there's, one of those eyes missing here. Now, do you know how to read this? Does anybody know how to read it? Well, I'll show it to you. See. Ho, I, u, chu, na, nu, kuna. See? That's how you read it, My 7-year-old daughter taught me how to read it. Yeah. So that's the thyroid hormone. Basically, the only difference is that there is an extra eye here, versus in T4 versus there is an eye missing. Anyways, so that's how it is. Now, when the thyroid, all organs need thyroid hormone. And when the organs need thyroid hormone, they take up T4, remove that iodine, and convert it into T3 and use it. So that's how it works, basically. Now, you might wonder, why does it have to be so complicated? Why doesn't the thyroid just secrete T3 and the tissues use it and, but because T3 is unstable, the half-life of T3 is very short. And that's why, thyroid needs to produce something which is more stable, can circulate in the blood forever, rather than something that just gets degraded by the time it reaches from the heart to, somewhere in the liver, So now you know why it has to be so complicated. Unfortunately, that complication kind of also boils down into how we treat the patients and all those things. So how is thyroid hormone regulated? Thyroid hormone is regulated by pituitary gland. That's like a peanut-sized gland, sits on the base of your brain. It monitors the thyroid hormone levels in your blood, and basically it's like a monitor, it's a sensor. And it produces TSH. And TSH is thyroid stimulating hormone. So what does it do? It stimulates thyroid. Easy. And so basically it stimulates the thyroid gland to produce thyroid hormone. Once again, this is boring, there's TSH, pituitary, those slide, it's like worthless, But that's important, okay? TSH is a very important thing because that is how the thyroid hormone, the thyroid gland is regulated. And think of it like a seesaw. So when you have hypothyroidism, your thyroid hormone levels drop low, TSH level goes up. Pituitary produces more TSH, which in turn goes and kicks your thyroid to produce more thyroid hormone. So basically in hypothyroidism, there's high TSH, low thyroid hormone. And then in hyperthyroidism, your thyroid hormone levels are high. So the pituitary says that there's too much thyroid hormone. We don't need to produce any more TSH. So the TSH level drops down. So that's basically, it's like a seesaw. So just remember, TSH high, thyroid hormone levels low. TSH low, thyroid hormone levels high. Simple. Right? Now hyperthyroidism is high thyroid hormone levels in your blood. Doesn't matter what the TSH is, it's high thyroid hormone levels in the blood. But in most of the cases, when the thyroid hormone levels in the blood are high, the TSH is low. And this hypothyroidism is low thyroid hormone levels in the blood. And in those cases, TSH is high. Now, some statistics, NHANES is like a large population-based study, something. 4.6% of US population has hypothyroidism. And out of that, only 0.6% manifests as symptoms like clinical hypothyroidism. The rest of them is subclinical, in which it just gets detected through routine labs. Patient might have some subtle symptoms, but non-specific things, and they might not know it, that they have it. So it's important to have those checked, routinely. Versus hyperthyroidism, it affects 1.3% of population, and out of that, half is clinical, half is subclinical. But in women, it's very common. It's like almost 5 to 7 times more common in women than in men. I don't know why, nobody knows why. But it's common in women. So hyperthyroidism, it's a zoom disorder. Zoom. Just remember zoom. Everything goes zoom. Fast. Everything goes fast. Zoom fast. Okay? Just think of those pictures. So what happens to the metabolism? Zoom. Weight loss. We lose weight. Your heart, what happens to the heart? Goes zoom. Palpitations, irregular heartbeat, all sorts of things. Your brain, zoom. Irritability, anxiety, nervousness, insomnia, all sorts of things, whatever your brain can think of can happen. Your skin, once again, zoom. Sweating, heat intolerance, feel hot. Your gut, zoom. Frequent bowel movements. Yeah, everything fast is fast, Your appetite, zoom, increased appetite. So that's important, appetite increase. Sometimes some patients overcompensate by eating more calories. So even though their metabolism is high, they gain weight with hyperthyroidism because they eat so much. And that can happen. But just to let you know. Your hands, again, zoom. Tremors, shakiness, jitteriness. Now there are some things that don't go zoom zoom, unfortunately. So it's like menstrual flow kind of actually goes down. You have lighter menstrual cycles and irregular. Fertility is impaired. Muscles, you feel tired, fatigue, tired. That happens. Sometimes you get this Graves' ophthalmopathy, which is like bulgy eyes, and that's autoimmune as well. Same antibodies that attack your thyroid gland also attack the muscles of your eye and make them bulgy and swollen. And actually smoking makes this worse. So you have to remember, if you are a smoker and if you have hyperthyroidism, that's a bad combination because you can have these kind of eyes. Yeah. Yeah. Yeah, those eyes photos should be on the cigarette boxes or something, Yeah. Anyway, so how does hyperthyroidism occur? I mean, there are different causes of why thyroid hormone levels go high in the blood. One of them is inflammation. It's like the thyroid gland gets inflamed like any other gland because of viral infection or whatever, and starts leaking out thyroid hormone. It's not actually overproducing it. It just leaks out whatever it has, stored hormone, and it keeps on leaking out for a few weeks, and after a few weeks it just goes back to normal. But that's what we call thyroiditis. It's just temporary. Versus autoimmune, in which the antibodies that start attacking your thyroid gland, the immune system, your own immune system starts attacking your thyroid gland. And in some cases, it irritates and stimulates the gland to overproduce thyroid hormone, and that's what we call Graves' disease. And those same antibodies, as I said, can attack the eyes. And sometimes there are some nodules, lumps in the thyroid that start overproducing thyroid hormone, without any control. So that's hyperthyroidism, overactive thyroid. Now, how do we treat hyperthyroidism? Basically, there are 3 treatment options. We cool the gland. If your gland is on fire, you cool the gland. It's simple. You give medications, methimazole and PTU. Both of them kind of suppress the thyroid function, cool the gland. Or you can kill the gland. You can kill the gland with radioactive iodine. So you just give iodine that is radioactive, and it basically kills off the gland. Or you can remove the gland. You just remove the gland, and the overactivity is gone. So those are the 3 treatment options. Now let's talk about hypothyroidism, which is low thyroid hormone levels. It's opposite of zoom zoom. You know what opposite of zoom zoom is? Which is moose moose. Everything goes slow. Moose, moose. That's what it is. Everything slows down. Your metabolism, moose, moose, weight gain. Your heart goes moose, moose. Slow heart rate. Your brain again goes moose, moose. Forgetfulness, depression, especially in elderly patients. Depression can be from hypothyroidism. Elderly patients don't manifest some of the routine symptoms, but can manifest as depression. So anytime a patient goes to a psychiatrist for depression, they will check the thyroid hormone levels and rule this out first. Your skin, once again, moose, moose, dry skin, coarse hair, feeling cold. Your gut, moose, moose, constipation, nothing moves fast. Your appetite, again, decreased appetite, But despite of decreased appetite, many times patients gain weight because your metabolism is so slow that your calories are not being used up. So that's the thing. Now, other things that can happen is like puffiness of eyes and face. That is separate from the bulgy eyes. It's mostly like puffy in the eyelids. Face becomes puffy and round. And then the menstrual cycles become heavy, and patients feel fatigued and tired because there's not much metabolism, going on. And how does hypothyroidism occur? Obviously, if you remove the thyroid gland, you become hypothyroid, and if you don't replace it with thyroid hormone. And then there is also an autoimmune destruction of thyroid. Graves' disease is autoimmune stimulation of thyroid, and there are different kind of antibodies that destroy the gland. And that's what we call Hashimoto's thyroiditis, in which there is autoimmune inflammation and destruction of the gland. And sometimes there is some age-related decline in thyroid hormone, so elderly patients are more prone to have some low thyroid hormone levels. Now, how do we treat hypothyroidism? Give thyroid hormone. Simple, give thyroid hormone. Levothyroxine, which is actually pure T4, is levothyroxine. That's simple. Or we can make it complicated. Give armored thyroid. Armored thyroid combination. Armored thyroid. So basically, what is armored thyroid? It's like they take pig, they remove the thyroid gland, make some powder, and I don't know what else they do, but that's porcine thyroid gland. That's what it is, It's natural. That's what they call it, natural, because it comes from pig, Now, why is the internet full of praises of armored thyroid? And if you Google hypothyroidism and if you treatment, then there will be like 20, 30 websites, and then on the blogs and everything, everybody will be praising armored thyroid. It's because patients feel better on armored thyroid compared to levothyroxine, and patients do feel better on armored thyroid. I'll explain why. Patients feel more energetic, able to lose weight better than Synthroid. Best thing ever happened to them. That's what the patients describe. I don't know if that is, but till the next thing that happens. But anyways, but that's what the patients describe it. That this is wonderful. This is miracle. Whatever. Yeah. Then why are not doctors prescribing it? Why are we not prescribing armored thyroid instead of levothyroxine? Why do we force people on levothyroxine? Is it because we don't want you to feel better? Is it because we don't want you to lose weight? Is it because we want you to come back to us with same symptoms again and again? Yeah, maybe, Yeah. No, actually not, okay? It's because of, first and foremost, the most important principle of medicine is, good. See, first do no harm. It's for safety reasons. It's really for safety reasons. Because armored thyroid has very high proportion of T3 compared to T4. And T3 is active thyroid hormone. So anytime you get T3, it's like a rush of caffeine, cocaine, whatever, gives you rush, But it does stimulate the heart. It gives your body kind of rush of energy. It stimulates the heart. But then, long term, it has potential for harm because it can stimulate the heart so much that it starts beating irregular, arrhythmias. It can get congestive heart failure after a while, to a point where we had to have patients do heart transplantation because the heart just fails. And it can be horrible. And sometimes you develop osteoporosis and all those things long term with armored thyroid. So that's why we don't prescribe armored thyroid in routine cases. Other common questions about the thyroid disorders, Now, my doctor says that my thyroid hormone levels are normal, but why do I have symptoms suggestive of hypothyroidism or hypothyroidism? Why do I keep on having those symptoms despite of normal thyroid hormone levels? It's a common clinical scenario that we encounter. It's because most symptoms are non-specific. It affects every organ in your body, and every organ in your body can have hundreds of different types of symptoms. which might or might not be related to thyroid hormones. And usually, perimenopausal women do experience some of the similar symptoms of similar to hypothyroidism, where they have kind of decreased energy levels, feel more tired, their menstrual cycles become irregular, gain weight, all sorts of things around menopause. And some of the symptoms are similar, but that's around that time is when those things start to happen, and many women feel that, gee, is it my thyroid? So how do we differentiate whether these symptoms are from menopause or from thyroid? We keep things simple. We just check the thyroid hormone levels. As simple as that. If your thyroid hormone levels are normal, then most likely your thyroid, the symptoms are not from thyroid. And how come? I do have symptoms, my thyroid hormone levels are normal, but I do still have symptoms. Why is it not from thyroid? Well, because if TSH is normal, then it's your own monitor, it's your own pituitary gland that is telling us that your thyroid hormone levels are normal, because it's your own monitor, your own pituitary gland. If it says that the TSH is normal, then that's what it is. So that's the thing. So then we cannot blame the symptoms on thyroid. Now, is there an exception? That can this still be thyroid? Yeah, if the pituitary gland itself has problems, and which sometimes happens, pituitary gland also can have tumors and all sorts of weird things, and that's when we call what we call secondary hypothyroidism or secondary hyperthyroidism. And those cases have to be interpreted differently. In those cases, the thyroid hormone levels are interpreted differently in a special way. That's kind of for the doctors to do. Now, I have hyperthyroidism and I'm still gaining weight. As I explained before, the appetite goes up, and some patients do overcompensate by overeating because the appetite is so ravenous that they just keep on eating and they gain weight despite of increased metabolism. And that happens a lot. Very high calorie consumption because you feel hungry all the time. Now, and there is another thing that patients are on levothyroxine, they still feel the same symptoms, feel tired, lack of energy. Right from the morning itself, you feel like, gee, I cannot function, right from the morning. And that happens, because Synthroid is pure T4, it's not the active form. So what we do, we sometimes do give a small dose of T3, which is pure T3, which is called leothyronine or cytomel. And sometimes we do give small safe dose of T3 to have more energy, and it's usually given twice a day because it's short acting and goes out of the system fast. But we do give a small dose of T3 in addition to Synthroid in some cases so that the patients feel more energetic. Not as much as Armathyroid, but we do give sometimes. Now, is thyroid hormone important in pregnancy? Well, the answer is yes, because everything is important in pregnancy. Extremely important, very, very important. Basically, thyroid hormone is necessary for developing brain, for developing intelligence and all those things for the baby. It's a very important hormone. And if you are hypothyroid and if you're pregnant, then we sometimes have to increase the dose of levothyroxine to provide adequate amount of thyroid hormone to yourself and to the fetus. Your thyroid hormone requirements go high. And the thyroid hormone levels are interpreted somewhat differently in a pregnant person versus non-pregnant person. It's a very important distinction to make because in pregnant women, we try to keep the thyroid hormone levels upper end of normal, the TSH somewhere lower end of normal, so that there is adequate amount of thyroid hormone to the baby. It's a very important thing. Now let's go to, that's thyroid function disorders. Now let's go to the anatomy, shape and size, thyroid lumps. Basically, it's like lumps. Very common. Thyroid nodules are extremely common. 50% of the population will have nodules. If I do ultrasound on all of you on here, almost half of you this side here probably will have thyroid nodules. So very common. Most of them are small. We cannot feel it. Most of them are benign. Nothing concerning. Most of them are inactive, don't overproduce thyroid hormone. That's boring, obviously. Nothing here. It's like small, inactive, benign, So what are we doing here? Why do doctors get concerned about thyroid nodules? Why? Because sometimes they can grow large and cause swallowing problems or cosmetic problems. They can be cancerous occasionally, and they can start overproducing thyroid hormones and cause high thyroid hormone levels, what we call toxic nodular goiter. And when do doctors get really, really concerned about the thyroid nodules? When do I do like this after, before going into the patient's room? If you have history of radiation to the neck, that increases your chance of cancer. I'm not talking about dental x-rays and all those things. That doesn't have big impact, but I'm talking about radiation for treatment of lymphoma or other cancers. And previously, back in 40 years ago, when doctors were practicing voodoo, they were giving radiation for treatment of acne. That's voodoo, that's what we call voodoo now. But that was a common practice 40 years ago, to give radiation for treatment of acne. It does help, and also for tonsillitis, I think for enlarged tonsils, they would radiate the tonsils. It's voodoo now, but it was practiced back then, Anyway, so if you have that history, then it's concerning, because later on you have a higher chance of developing thyroid cancer. If you have a family history of thyroid cancer, in particularly if you have family history of medullary thyroid cancer, it's a very concerning thing. If you are developing hoarseness of voice, not temporary hoarseness, if you shout for 20 minutes like I'm going to develop hoarseness, but permanent hoarseness, if you are having difficulty swallowing, which is getting worse, or if the nodule is stuck to the surrounding tissues and it's not movable, what we call fixed nodule, these are all signs that that the chance of cancer in the nodule is higher. So what do we do about thyroid nodules? Well, we just do a thyroid ultrasound, uptake and scan, biopsy, surgery, all sorts of things. So thyroid ultrasound is the best modality to measure the size of nodules. So even if sometimes the thyroid nodules get discovered on a CT scan, we still do a thyroid ultrasound, because that is how we delineate the nodules, the size of the nodules, and that is how we discover if there are any suspicious features for nodules, like irregular margins and vascularity and all sorts of things we can detect from ultrasound. And we also do this as baseline and then monitor it over time to make sure that the nodules are not growing. That's what the ultrasound is for. And then sometimes we do this radioactive iodine uptake and scan, and we do that's to find out if there are any overactive and functional nodules, kind of hot nodules, and there are some versus there are inactive nodules versus like cold nodules. So if you see, anybody can say where is the hot part? This is the hot part. Where is the cold part? This is the cold part. Hot part is like basically appears black. It's like a black hole, and the cold part is white. So that's how it is. So the reason that we do this is because hot nodules are less likely to be cancer. It's a good news, It's like a good news, bad news situation. It's not cancer, but it's overproducing thyroid hormone, so you still need to take care of it. But at least it's not cancer. So depending upon it's good news or bad news. Versus cold nodules can be suspicious for cancer. And then we do biopsy. We do biopsy of those cold nodules, try to fish out if there's any cancer or not, and then take it from. And sometimes, obviously, we have to remove the thyroid. So why do we remove the thyroid? If the nodule is cancerous, if the nodule is causing swallowing problems, or if the nodule is having cosmetic disfigurement of the neck. So the first indication, the cancer part, we decide. The other two part is you decide. How badly your thyroid is affecting your quality of life, and if you feel that it is quite a bit, it's affecting it severely, and you want it to be removed, well, it can be considered. But you have to mind that anytime a patient goes for surgery, there is always a risk of dying on the table, as simple as that. And with thyroid cancer, there is a risk of damaging the nerve that goes to the voice box and losing the voice. So we don't take thyroid surgery lightly. We don't just, refer all patients to surgery when we discover nodule, unless there are specific indications. Now, the thyroid cancer, there are 4 types of thyroid cancer: papillary, follicular, medullary, and anaplastic. Papillary is the most common and excellent prognosis. 10-year prognosis is almost 90 to 95%. So that's good compared to, if you compare with like a breast cancer or colon cancer or prostate cancer, this is a very good prognosis, So your chance of dying from thyroid cancer, papillary thyroid cancer, is low, unless it has spread around into bones or something. Most of them are treated with radioactive iodine and follow with thyroidectomy followed by radioactive iodine. So basically surgery and radioactive iodine takes care of everything. Thank you.